I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We've come a long way in the treatment of early stage lung cancer. Lung cancer, obviously, there's many different treatment modalities for lung cancer patients, but one of the treatment strategies that offers the best chance for cure is surgery. And surgery should be considered for patients who are surgical candidates or fit and have disease usually confined to one area of the lung. And it's always important that patients get a evaluation by a surgeon, a thoracic surgeon, hopefully, to determine their candidacy and see if the tumor that they have is what we call surgically resectable. And if that surgery is able to be done, we know oftentimes the work is not done. There are, even when the surgeon is a good one and an experienced one and removes the tumor and removes it completely, we know, unfortunately, that recurrences can occur. And because of that, we really try to have a conversation with the patient about the role of additional treatments. And what we now know is that for patients with tumors greater than 4 centimeters on the pathological specimen, I mean, it was removed, the pathologist measured it, and it was 4 centimeters or more, or for patients who have nodal disease, so that the cancer moved from the tumor to regional nodes, and they will again assess that on the pathological specimen. Those patients should be considered for adjuvant chemotherapy. Adjuvant means essentially after treatment, after surgery. And so I have a conversation with all of these patients about the benefits and the risks. That's so critical to truly talk to patients about both the benefits and the risks. Number one, patients should be offered cisplatin-based chemotherapy. That is the standard. I've seen carboplatin substituted, but if you want to go by the data, it really should be cisplatin-based chemotherapy for 4 cycles. Depending on the histology of the tumor, so there's 2 types of lung cancer generally within non-small cell. There's adenocarcinoma and there's squamous. Patients who have adenocarcinoma resected lung cancer, I will generally offer cisplatin with pemetrexed for 4 cycles. Patients who have a squamous cell lung cancer resected or removed who are eligible for chemotherapy, that's where things get a little bit more nuanced, but I generally offer cisplatin with gemcitabine. There are others who offer cisplatin with a taxane. That's perfectly acceptable as well. So these patients, again, 4 centimeters or more, or a nodal disease, should be offered 4 cycles of a platinum-based chemotherapy, preferably cisplatin, with what I call histology-directed partner of either pemetrexed if they have adenocarcinoma or gemcitabine taxane if they have squamous cell. Perhaps the most important component of this discussion is the benefits and the risks. And this is where I think a lot of oncologists may get tripped up, because what's important to convey to patients is that we're going to, of course, offer you 4 cycles of chemotherapy, but I'm realistic about what the benefits truly are. And those benefits are that it usually provides an improvement in survival at 5 years, anywhere from 5 to 15%. So I tell patients, depending on the stage, at 5 years, you have X amount of chance to be alive. But if we add in chemotherapy, that chance goes up another 5 to 15% at 5 years. And we look at cure at 5 years. So we also need to talk about the risks. And this is not a easy chemotherapy to get to, but it's one that we can get most patients through. So we need to remind them of the toxicities, of the cytopenias, of the nephrotoxicity or kidney problems, potential hearing issues that we need to remind people of, and overall GI toxicities as well as low blood counts. Those are the things that I really talk to my patients about. And depending on the partner that we're using with the platinum, there may be some hair loss as well. But at least with the cisplatin pemetrexed, there's really very little hair loss. So in summary, patients that have 4 centimeter tumors removed and or nodal disease involved should be considered for adjuvant cisplatin-based chemotherapy. The treatment is given every 3 weeks for 4 times. There are side effects that definitely the oncologist needs to go over with the patient. Also needs to go over the realistic benefits of this, because some patients will say, if the benefit is only 5% at 5 years, I'm not sure if I want to go through this. I have to tell patients, even if I give you this, this is not a 100% guarantee that it's going to work. We know on average it improves your chances of survival at 5 years, but it doesn't bump up to 100%. And that's just the balance of me being realistic at the same time being optimistic. Lastly, I want to say that the field is changing, and it's important that patients understand the molecular markers of their resected tumor. Patients that have an EGFR mutation in their tumor are not only eligible for the adjuvant chemotherapy that I just discussed, but they're also eligible for a pill as well, osimertinib. And so I would ask that every patient really talk to their surgeon and ask them, did molecular testing get done? And if so, what were the results? Because we're just beginning to scratch the surface on the role of precision medicine or targeted therapies for early stage lung cancer.